This is the Psychcast by MD Edge, where we bring you interviews with leaders in the fields of psychiatry and psychology, masterclass lectures, and relevant inspiration, with new episodes dropping on Wednesdays. I'm the voice of MD Edge Podcast, Nick Andrews. And welcome to episode 106 of the Psychcast by MD Edge, the official podcast of MD Edge Psychiatry. In episode 106, Editor-in-Chief of MD Edge Psychiatry, Dr. Lorenzo Norris, welcomes Dr. Nina Gutin to talk about losing a patient to suicide. Remember that this episode comes with robust show notes authored by Dr. Jacqueline Posada. They include an outline, a summary, and relevant links to topics referenced in the conversation. The notes are available wherever notes are found in your app. But before we begin, I wanted to update you on the 2020 annual APA meeting, which is slated to take place in late April 2020 in Philadelphia. As you may have heard, various specialty societies across medicine and in the US and in Europe have canceled recent meetings, including the American College of Cardiology and the American Academy of Dermatology. As of the publication of this episode, MD Edge can report that the APA meeting is still happening. Of course, that is subject to change, and we will keep you updated in the events of a change. You can stay up to date with all of that information at mdedge.com/psychiatry. Okay, without further delay, please welcome Dr. Lorenzo Norris.
Hi, my name is Dr. Nina Gutin, and I'm a psychologist with, among other things, a private practice in Pasadena, California.
Hello, this is Dr. Lorenzo Norris, Editor-in-Chief of MD Edge Psychiatry. I want to welcome you to today's Psychcast, where we're privileged to be joined by Dr. Nina Gutin. Dr. Gutin is going to be talking with us today about an extremely important subject, and that involves what happens when we as physicians, clinicians, psychologists, all of us as mental health providers, lose a patient to suicide. Dr. Gutin has recently published an article in regards to this on MD Edge Psychiatry, and we will give you the link to that at the end of the interview. So again, Dr. Gutin, I want to thank you for coming to the Psychcast and joining us today.
Happy to join you.
Okay. All right, Dr. Gutin, I guess maybe as we start out, maybe the first thing that I want to ask you is, what prompted you to write about this subject, Dr. Gutin?
Well, actually, when I was in graduate school studying to be a clinical psychologist, I lost my brother to suicide and noticed that not only did it have an impact on my personal life, but it impacted me certainly as a clinician to be and in the clinical work that I was doing. I tried to find someone who was talking about that and wasn't able to, and so decided to do a presentation about it. And when I did that, clinicians came out of the woodwork and said, I've had this too, but there was nowhere else to talk about it. And so since then, I've educated myself as much as possible on the impact of not only losing loved ones, but also of losing clients, and have integrated that into the work that I do with one of my colleagues, Vanessa McGann, through the American Association of Suicidology, and providing the Clinician Survivors Task Force, which is to provide spaces and for clinicians to be able to talk about this experience and resources to support them.
Okay. Well, thank you for sharing that with us, Dr. Gutin. Now, in regards to losing a patient to suicide, can you just talk with us or outline for our audience, if you will, just some of the things that we have to think about in terms of what the general impact of that is for clinicians, mental health providers, when they experience the loss of a patient to suicide?
Well, first of all, I'll say that the impact on a personal level is very consistent with the impact of non-clinicians, which is that it is a traumatic loss. It really shatters a lot of assumptions around one's own and other people's agency and all sorts of other things. It's also a very stigmatized loss, and we'll be talking a little bit more about that. And the intensity and the duration has been shown to be far greater than for other types of losses. So that's just on the personal level. And then for clinicians, there are additional factors, number one being the confidentiality-related restraints and constraints on the ability to discuss and process the loss. I mean, one of the things about moving through loss and processing it and integrating it is being able to have places where you can discuss this and you can share memories and you can talk about the impact that the person had on you. And it gets complicated when there are confidentiality issues involved and people are given the message, implicit or explicit, that you cannot talk about this. Mm-hmm. Then the potentiality for any types of other legal issues like a lawsuit can be terrifying, to say the least. And, and some of the other ethical issues, like simply having the psychological review or the autopsy or whatever it's called afterwards, raises issues about, am I going to be able to keep my job? Am I going to be censured? What are the implications for this career that I've chosen? So it sort of goes beyond the personal in that respect. And then there's, the fact that there's a lot of documentation that reactions from colleagues, psychiatric colleagues, other mental health colleagues, including supervisors, have traditionally been less than optimal, often shaming and blaming, which just sort of adds to the stigma. And then last but not least is the fact that experiencing the loss of a patient or a client to suicide is quite likely to affect one's subsequent clinical work. Mm-hmm. Often people feel like they've become hypervigilant in relation to other potential clients who might have potential suicidology and just sort of see it where it's not there. Conversely, other people have described about sort of being in denial about it and just, it's too distressing to even think about it, so they don't even ask the questions when it's appropriate. So you can see all of these different domains in which the impact can manifest itself.
Dr. Gutin, you gave us an excellent, if you will, overview of, I think, a very useful thing in terms of those 5 domains of confidentiality, legal issues, ethical considerations, including one's ability to practice, documentation considerations, as well as the impact of this on one's clinical work. You started off by speaking about, if you will, also how the loss actually, in terms of personal, in regards to loss of agency, stigmatization of the loss, as well as intensity and duration of it. And as you were speaking, I was thinking about how the personal aspect of the loss of anyone to someone, for the personal loss of someone to when someone has died by suicide in their life, overlaps with many clinicians or health professionals with many of the things that are, if you will, clinician or mental health provider specific. So I did want to start to maybe delve a little bit more into those issues and just even give a little bit of my perspective, having been a former medical director of psychiatric services at GW Hospital. The confidentiality issue, just to start with that is really a big one because confidentiality can, in psychiatry is sacrosanct, essentially. So when you lose a patient to suicide, that ability to even discuss it with, depending on colleagues or with anyone else, becomes extremely, extremely limiting. And I found that whether it's in trainees or other attendings, the confidentiality in and of itself, in terms of the impact, you have this really, for most clinicians, I would probably say for many, certainly a traumatic level event that they feel limited in terms of discussing.
Yeah.
And then when you also brought up, and I didn't want to touch base on this, not only can you not discuss it, or you have very limited ability to discuss it, it is the legal issues. I do not know how people in the psychcast who have maybe had the unfortunate experience, that traumatic experience of losing a patient to suicide or any type of adverse event, really realize immediately the effects of a lawsuit. The moment there's a lawsuit, basically everything stops. There can be really no communication about it. The chart, whether you're private practice or if you're in a hospital setting, whether you're using Take Your Pick, Epic, Cerner, or anything of that nature, you can't go in the chart. You can't review anything. You normally have to, if there is a review, it has to be done, if you will, in the auspice of a review covered by, our lawyers and medical malpractice, things of that nature. And that once you have the confidentiality aspect as well as the legal issue aspects, that just creates a, in terms of even trying to process it, whereas however you might process any other forms of loss, it just creates I guess I'll just use the word cloud, barrier, obstacle, in terms of thinking about it. Yeah, yes, absolutely. Please, Dr. Gutin, go ahead. Yes.
Yeah, I think people have described that they felt like they were dealing with all of this in isolation, in a vacuum, that they were sort of walking around faking it as much as they could, but there was, there was no place that, at least that they saw, where they could actually talk about what was going on with them. And it's, that talking about that just adds so much insult to the injury. And so, which is why, we felt like we needed to do something, which was why we have the Clinician Survivor Task Force, because that provides a way for people to maintain the anonymity of their clients and of themselves if they want to. We can actually disguise their email addresses if they want to, and be able to talk about their experiences to other clinician survivors. It's a way of sort of like letting a little bit of air into the vacuum.
Okay. Well, we're going to talk about this task force a little bit down later. I did want to follow up with, because again, that idea of it creating a vacuum. Again, we started with the confidentiality and the legal issues. The other thing that you brought up, which I think is huge, is there's a very real consideration with many clinicians, if you will. One, am I actually going to be able to practice? And second, it absolutely affects your clinical work, regardless of whether you've lost someone to suicide or not. But and why do I say or not? I frequently find in my role in terms of trainees or fellow junior attendings, if a patient's been lost to suicide, not only is that clinician affected, but all of the clinicians around that person are affected. Everyone gets a little bit more tighter, a little bit more hypervigilant, maybe a tad more risk averse. So the effects extend not only with that clinician, but to the system as a whole. And with some of those other things that are going on, it's, again, that vacuum. It's kind of, this has happened, but no one's able really to speak about it. And you're not able to process it. Not only can you not process it as an individual, you can't process it, if you will, as a team. And I was wondering if you could speak to us about how, again, stigma plays a role in all of this. I was wondering if you could speak with us in terms of the challenge of stigma and dealing with the impact of losing a patient to suicide.
Well, I want to sort of separate out the two issues that often get intertwined. One of which is the stigma, and one of which are the actual real legal and ethical constraints around discussion. And they, as I say, it's hard sometimes when you're in the midst of it to separate out one from the other. But with the stigma, to speak as if it is separable, one of the things that happens is, as we know, there's so much stigma around suicide, and the studies have been really clear that stigma extends to the survivors of a suicide loss, who are generally seen as more blameworthy and less worthy of support than survivors of other types of loss. And for a clinician, the way this has tended to for clinicians, this is manifested in terms of implicit or explicitly expressed blame. and towards the treating clinician, which has absolutely nothing to do with whether or not that blame is warranted. Because as we know, this can happen to anyone. You can do everything, quote unquote, right, and still lose patients and clients to suicide, but nevertheless, the blame is there. And I often think that blame, both guilt and blame, are sort of the flip sides of each other in both ways of deflecting the complexity and the ambiguity involved in these losses. That if you can either blame yourself or blame someone else, it's much easier. But nevertheless, that exists within our clinical communities. And I also think in terms of the stigma, there's not only stigma around the suicide loss, but I also think there's a stigma around professionally expressed vulnerability, which is predicated on this us-them distinction. We are the strong ones. We're the healers. We're the doctors. They are our patients who are the ones who are sick, who are pathological. And so what happens when if a doctor becomes vulnerable and manages to express that vulnerability, it can, throw that dichotomy into a bit of a tizzy. And the way that people react to it is by shoring up their identities and then pathologizing the person who has dared to express their vulnerability. Oh, now you're one of them. And so we often hear clinician survivors talk about how, not only were they blamed, but that their normative grief was actually pathologized and was seen as inappropriate within a professional capacity, as though, these two existed, in silos apart from each other, which again makes it very difficult to integrate the loss when you're told that, they have to, in order to be a professional, you've got to be in denial about the way that this has impacted you.
Well, yeah, I would absolutely agree with that. I think about those wherever you're practicing, whether outpatient, inpatient. We are, in terms of our, for better or worse, in terms of our professional standard, that aspect of professionalism, stoicism, being able to continue. You may have lost a patient to suicide, and so for many folks, you end up going back to work the next day or within a day or two, and you are still seeing, I'll speak from my own personal wheelhouse in terms of inpatient psychiatry, patients that are at high risk, very high risk in an urban medical setting. So and maybe an unwritten or implicit is that you have to keep on going on because if you don't, that will just further exacerbate the perception of either you showing too much vulnerability, or it will exacerbate the idea that maybe you were in some way, shape, or form more to blame for this than people would, maybe suspect. So where am I going with this? I think that there's a lot of pressures on clinicians, particularly psychiatrists, in my opinion, when a patient is lost to suicide. And I would dare say I haven't looked at a study on this in any way, shape, or form, but when I've talked informally with some of my other colleagues who have lost patients for a variety of other reasons or conditions, the impact of a loss of suicide in terms of the field of psychiatry, in my opinion, is just felt much differently, and I would dare say on a much more personal level. That is just my impression informally after talking with various clinicians in different fields.
Yeah, and I think it's definitely it's both personal and professional.
Yes.
And when your profession says that in order to sort of be a respected member of this profession, you have got to, hide the impact, certainly of the personal, but even the professional, and continue on as though there were no impact in order to stay in the respected sphere.
Yeah, I really think that in certain many ways that hampers our profession. I couldn't imagine if an oncologist, say for example, refused to treat a patient with like stage 4 metastatic cancer because they were concerned that they were going to be blamed for the loss of the patient. I think sometimes in psychiatry, this gets back into the impact in terms of clinical. I can't speak for all psychiatrists in any way, shape, or form. Again, this is just an impression. But if the standard in psychiatry is that, whether formally or informally, but it's out like, you don't lose patients to suicide, that affects your practice. That affects who you treat. That affects who you offer services to, as opposed to being acknowledged for actually working in a collaborative spirit with your patient to take that risk for someone who really absolutely needs your assistance. So, I think that this is our inability at times to talk about this in an open fashion and give support to our clinician survivors who've lost a patient to suicide hampers our profession as a whole, because we know suicide rates are rising. So this is something that we absolutely need to support our fellow clinicians in. And also going back to what you said, this can absolutely happen to any of us. Absolutely.
Right.
Now,
I was just going to say, and luckily there are people within the mental health field and within psychiatry who are working to change the culture,
yes.
Both in terms of understanding suicide as an occupational hazard that needs to be prepared for, and ahead of time, rather than just this anomaly that only happens to bad clinicians, particularly when the rates are so high within psychiatry.
Absolutely.
And so there, there are good people who, Jeff Sun, Mike Myers, who are really working to change the culture within psychiatry.
Okay. Now, with that being said, Dr. Gutin, can you tell us a little bit about, because we've talked about, if you will, the impact, we've talked about stigma. I was wondering if you could now elaborate a bit more in terms of how can we support clinician survivors? What things are out there? I mean, you mentioned a bit more, talked about the Clinician Survivor Task Force, but could you tell us and educate us a bit in terms of how clinicians can support themselves if they have lost a patient to suicide, and how we can support our fellow clinicians?
I think I'll start with the latter by saying that, any type of organization, institute, hospital setting that where there's a treatment of clients should optimally have what we will call postvention protocols in place. In other words, protocols that deal with the potential for losing a client, a patient to suicide before it actually occurs, so that they're not scrambling to figure out what to do when it actually does occur. And and to have in that guidelines for each part of the process, for what type of communication needs to occur, what needs to occur during the review of the event. During that review, that would include things like being able to balance the needs of the institution to obtain the information necessary with the emotional needs of the affected clinicians. Often that gets completely neglected, and people have described it as feeling like a tribunal. And have the purpose of that be to, understand what happened, to identify any mistakes at any of the levels, not just the person's the treatment level, but communication between various agencies, the communication with the family, say during a path, all of these things, and that optimally can be learned from. So not to be used to blame, but to be used for future learning and to sort of maybe, see where there might be gaps in the system that need to be sort of bolstered up. Okay, I just got a little bit derailed. What was the...
No, that was how can we support clinicians in regards to the impact of suicide? What are ways in which we can support clinician survivors? Mm-hmm.
Yeah, well, the other thing in terms of, from the institutional level is to really be as knowledgeable as possible about what the normal sequelae of this loss is. That it's likely to affect someone personally, it's likely to impact their clinical work, and to really provide supports and resources for the impacted clinicians so that they're able to really look at this without a sense of shame and closing down, but to be able to say, okay, what are we looking for? Do you notice any impact? Do you feel like it might be helpful to have a temporary reduction in the number of high-risk patients that you're seeing? And can we make accommodations for that? So to sort of integrate the understanding of this impact into the sort of organizational, institutional levels in order to support them. On a more personal basis, provide spaces where they can talk about what this is like while still preserving the confidentiality of their client, and also to have that extended to the understanding of how to deal with any impact, any interaction with the patient's family. And I'll just really quickly say that, and this comes from lawyers who have expertise specifically in suicide loss. And what they talk about is compassion over caution. And that you don't have to betray a client's confidentiality by reaching out to the family members and expressing concern and condolences and offering them ways to support themselves. And that, and within that, you still need to understand, who is the holder of the privilege and what can and cannot be disclosed. But even when you absolutely cannot disclose anything, there are still things that you can do. And basically, the research has shown that when clinicians do that, it's actually more healing both for the families and for the clinicians, and that compassionate family outreach actually reduces the possibility of a lawsuit. Because from the family's perspective, when they call the clinician and the clinician says, I can't talk to you, that increases to their sense of anger and, they must be hiding something. And so that actually increases the risk of a lawsuit. So this, the interaction, compassionate interaction actually reduces that risk. And so back to, the ability to provide both consultation and abilities for clinicians to talk with each other. And if there's anyone on staff who has already experienced that and who knows what that was like, reach out to the impacted clinician. Say, hey, I'm just imagining what you might be going through. I went through the same thing. I know how hard it is. And I just want to let you know that, obviously without betraying any specific information about your patient, we can talk about our experiences. And because the number one thing that at least from my experience, that clinicians have found helpful is to feel like, I'm not alone. Someone else gets it. I can, and it's just such a relief to be able to sort of unburden yourself and have your own feelings not only out there but also validated.
Well, I agree with everything that you said, Dr. Gutin. In particular, when I think about it, I mean, just kind of breaking down some of the things that I heard, and even from my own experience, that idea of, if you will, focusing on the system and what errors occurred, if any errors occurred, because not all the time errors occurred, but if you, depending on where you're at, even if you're in a private practice or if you're in an institution, if you have a method in which you can actually convene everyone and you can actually discuss the case and actually look at the system level occurrences, I've found that particularly very, 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 very helpful. I lead the medical and mobility rounds for our department, so I've had experience with this, and I agree with you completely that once we take a look at system, and the other thing that you said is that in those meetings or when you convene that group, if the spirit is one of learning and education, I find that extremely, extremely healing and therapeutic. But before you even get to the, if you will, that level of intervention, I thought what you just said in regards to the isolation, which I find is the most hard part for clinicians, particularly acutely. If you have a designated member of your department or your practice, particularly a peer that has gone through this, that is invaluable to reach out immediately to the clinicians. And I think when you address the isolation, and you have the system level intervention or education, that immediately starts to cut into the stigma and the blame, because in my experience, it's never just one, if you will, event or one, if you will, this, that, or the other. It's usually a system-level phenomenon in which we kind of say like all the holes of the Swiss cheese line up together. Sometimes it's not. But again, if we have the spirit of how can we learn and improve so that we can better serve our patients, I think that really addresses a lot of things and helps clinicians start to process this loss,
Yes.
as well, not only clinicians, but the whole system entirely. And that, to me, is always the best part, when the system as a whole rallies around itself to support themselves in regards to this. I was wondering if you could speak a little bit about the Clinician Survivor Task Force.
Sure. Well, the task force was originally created, I think it was in 1987.
Yeah, it's 1987, yes.
Right. By, Judy Mead and
Frank Jones and Judy Mead, I believe.
Frank Jones, yes. I was like, there are a number of Franks who I know. I just want to make sure I had the last name correctly. And I remember, shortly after I had lost my brother, going to a meeting, and there were like two people there. It wasn't very big. And Judy Mead was there, and I said, well, I lost my brother. Would I be able to join? And she said, no, this is really specifically for people who have lost patients and clients. And the reason was that she had actually tried to go to a support group for survivors of suicide loss and was given the message that you're not a survivor, you're a clinician, and there's no room for you here. So they had felt very strongly that there was a need for clinicians to have a space to process this loss, to share it with each other, and to feel like they could break the isolation. And so when about a year after I had originally asked to join, I tried to make the case that there was probably enough overlap for clinicians who had lost family members, loved ones, etc., in the sense that that there was both personal and professional impact, that even though they weren't identical, we could support each other. And she said, okay, but then I'm retiring, can you take over the task force? And that was, I think, in 2002. So since then, the task force has existed to support clinicians who have experienced any type of suicide loss. And we have people there who have lost their own therapist to suicide. We have people there who have lost colleagues, and we and basically it's an online support group, among other things, where people can share their stories. I.e., if it's a patient, obviously, hiding any identifying details, and we'll get support from other people who understand that, who will basically offer advice based on what they went through. If they're going through the lawsuit, you can hear from people who've been through that and what was helpful for them. We actually have the option to do video support groups, and what we do is we try to separate those out for clinicians who have lost loved ones as opposed to patients and clients. And actually, surprisingly, a high number of people have lost both. So we try to provide as many supports as possible. We are very lucky to have a now retired John McIntosh, who in all of his spare time keeps our bibliography up to date on anything that's ever been written in this topic. We have testimonials. We have a number of really good postvention protocols posted on our website, and so we're trying to do what we can to sort of create the space to sort of that's the antidote to the vacuum and the isolation, so that people can feel that they're not alone. They can actually have an opportunity to connect with other clinician survivors, to get support, and then when they're healed enough to offer support. And that post-traumatic growth piece, the feeling that, okay, I'm in a place now where I want to be able to use my experience to support others, is one of the things that is so helpful about this, because I think that's, this happens so often, that when people get good support and they're able to develop a sense of gratitude and a desire to sort of pay it forward in that way.
Okay. All right, Dr. Gutin, I want to thank you for those words. I really like that antidote to the vacuum, and also the post-traumatic growth, and really what you just said in regards to pay it forward. If through the work of clinicians like yourself, as well as others, I mean, certainly we're talking more about clinicians who lose a patient to suicide. We're really starting to target, if you will, or think about the unnecessary stigma that is associated with this. And you've touched upon many times in terms of the damaging effects of isolation, as well as stigma, in terms of the clinician, if you will, healing, recovering, and learning from this, and getting to that place to where they actually can experience growth from this. And I would dare say that if we can, you talked about losing a patient to suicide, or you mentioned it as, if you will, an occupational hazard, and it's something that it can happen to any of us, and we certainly, if it does not happen to you will most absolutely have a fellow colleague in which this does happen to. And I guess what I've heard from you, what it makes me think about, is that being vulnerable is not a sign of, if you will, professional weakness or vulnerability, but being vulnerable and seeking out support and not being in isolation is actually, if you will, a validating and a marker of your professionalism. And I think that if we can move in that direction, we're going to be better able to support ourselves as well as serve our patients. So, Dr. Gutin, I want to thank you so very much for joining us on the Psychcast today and speaking with us about a very important subject.
And that concludes episode 106 of the Psychcast by MD Edge. I'm Nick Andrews. Let's get to this week's credits. The Psychcast is produced by editors Gina Henderson and Jeff Bauer. It's hosted and produced by the editor-in-chief of MD Edge Psychiatry, Dr. Lorenzo Norris. The show notes are authored by Dr. Jacqueline Posada. All of MD Edge podcasts are produced by our editor-in-chief, Dr. Ivan Aransky, as well as executive editors Kathy Scarbeck and Mary Ellen Schneider, and multimedia editor Terry Rudd. Social media is produced by Kyla Clark. I'm the voice of MD Edge Podcast, Nick Andrews. You're listening to the Psychcast.